Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations. Welcome to another episode of Life in Sirens. This is going to be a little fireside chat, but we were just chatting, sitting around before we recorded our next episode about scene times. And I brought up that I feel like my scene times have gotten a little bit longer. Aubrey reminded me that I'm still like well under.
Yeah.
Yeah, by long we mean like 12 minutes instead of 7.
Instead of 7. We're still like well under, but they've been getting a little longer. And it's because we've been doing a lot more like thorough patient care prior to transporting, and it just kind of got on the topic, and Aubrey said a phrase that really like tickled my brain in the right way, and I want you to say it again.
So Jamie's concern was what she said was, I am concerned because I am delaying transport to do these interventions that maybe aren't critical to the patient, but in reality we should not be calling it delayed transportation. You are swapping time, because what you are doing on scene is exactly what they're going to have to do when you get to a room in the ER. And we all know that once you get to the ER, you have to go through registration. The physician has to come in, put in an order set, and then all of those things can be done. So there's a delay. There's going to be a known absolute delay there, which is inevitable, and that has to happen. That's fine. But if we have the opportunity and the ability and the protocol to do that for our patient on scene, it is not a delay of transport. You're swapping time with the ER. That's all you're doing.
And I think that's a fantastic explanation.
I agree.
For why.
It honestly just depends on how your system works, what's most appropriate. Like,
For
this
sure.
is not like a standard across the board. Like, it's going to be different based on your area.
Well, and that's kind of thinking about on that same field. I think that really, really short scene times where people just like literally load and go. I think there's a time and a place for that.
Absolutely.
But I also think that you can be like borderline negligent by doing that, because like you have a critical patient that you just like grab it and you just take off, and they're critically ill. Well, if you don't do anything, and then you get to the ER and they have to do all the things you didn't do.
Yeah.
So let's say they don't have access and they haven't gotten like fluids or whatever it is that they might need. And then the ER has to then double back and do all of those things that you didn't do. And then it orders and meds. I mean, realistically, it's 35 minutes to an hour before they actually get any intervention.
Right. And there's
so
never
that
an
extra
ER.
5 minutes on scene could have led to like an hour faster.
And we're 2-to-1 care.
Yeah.
Mm-hmm.
There's never an ER that is less than probably 4-to-1.
Yeah.
Like,
for
that
sure.
doesn't exist.
We were at a conference not too long ago, and there was one of the trauma docs at a level 1 trauma center here in our state. He said something that really, I was so happy that he said it, and it resonated, not because I haven't believed in it before, but I was so happy to hear a doctor at a trauma center stand up in front of a bunch of EMS providers and say this. He said, the single greatest thing that you can do for your trauma patients is get access on them. This is what he said. I have watched more people die in a trauma bay from lack of access than I have anything else. And like, God, that is, I don't know why, but that is such a hot topic in EMS. Like, obviously with traumas, you have to be like the golden hour and all of those things, and you have to be mindful of that. But I know that we brag a lot about like, oh, we do everything an ER does, but we do it 60 miles an hour. Okay, well, in reality, that is not always feasible. There are some things you cannot adequately do going 60 miles an hour.
Right. Have you ever tried to get a 12 lead?
Yes.
Going 60 miles an hour, it's not good.
It's VTAC.
It's VTAC.
Honestly, I thought when I started flying, doing
It's
12
A-flutter.
leads in the air would be like a really big problem. It's actually way better than going down the road. But it's like vibrating the whole time, but it's still
good.
Still better.
Maybe it's just more consistent, so the monitor can like kick it out.
Yeah, that's fair.
Yeah, read through it.
Mm.
But yeah,
I love that.
It's the same medicine that we've been doing for 20 years.
Mm-hmm.
I just don't know why we're still confused about it, you know?
Yeah, I think that there is a time and a place. If you're a provider that spends an hour on scene trying to get a line, clearly that is not appropriate.
That's silly.
But if you delay by 5 minutes
Right.
to get bilateral 18s or whatever it is that you need for your patient, then that makes their care that much quicker when they get to the hospital.
Yeah.
And realistically, in the hospital, it's not a 5-minute delay.
Because, and you're right, there is a time and a place for everything. But we are to the point in pre-hospital med that we are able to do more than just critical life-saving interventions.
Mm-hmm.
And there is a time and a place for everything, like with trauma calls. If you don't carry blood, what are those bilateral 18s going to do for you? I mean, you can do some sort of fluid replacement, but in the grand scheme of things, your definitive care is going to be at an
100%.
ER with blood products, right? But with like septic patients, we have the fix for that.
You have a lot of
If you have a
answers.
hemodynamically compromised septic patient, you can get access and do something about it,
Well,
right?
Yeah, you can stabilize that human until they can get antibiotics and get all the things.
There are things that they need and that we have.
Yeah.
Like, it doesn't matter. I know there's the debate of, like, we're close to the hospital. Okay, take that out of it. We're not talking about that. Scene time is not a metric that can, like, appropriately assess, like, quality of care.
Mm-hmm.
Like, I get really frustrated because, like, I was going to say this before, we have more protocols. Like, there's a reason we have more protocols, and just because they're not going to, I hear this a lot, too, on social media, is that, like, if they're not going to die right now, then I'm not going to do it. Like, if the intervention that I'm doing right now isn't going to fix them right this second, then I'm not going to do it. Or if it's not going to turn them around, I hear that a lot. I know you guys do, too. If it's not going to turn them around in front of me or fix them in front of me, then I'm just going to wait. What? That's kind of like some psychopath behavior,
Right.
I'm just saying.
And we've talked about that. But that is basically like, if I don't get the instant gratification, it's not worth it.
Right.
And we've talked about that before in the context of, like, what if other medical professionals did that? Like, what if the ER was like, we're just not going to do that because the ICU will do it.
That's weird.
Right? They do that with, like, cleaning patients, but, you know, not like critical interventions.
Right.
Or what if they were like, I know that the cath lab is going to want more access, but they can just do it themselves.
Yeah.
Or I know that CT wants an IV above the AC, idealistically. They can do it themselves. I don't want to because we're not going to use it.
Yeah.
Because we have one in the hand. You know, like, if other areas of medicine did that, it would be a problem because it delays care for everybody involved.
And it is a problem.
Mm-hmm. And it's weird to me when we say, like, even down to if you're not going to use it, don't start it. Like, down to the IVs. Like, if you're not going to use it, don't start it. And I don't love that either.
Yeah.
Because, again, once they get to an ER, it's 20 minutes before any care even starts happening for them, unless they are, like, critically ill.
There's also many hospitals that say if you're admitted, whether we're using an IV or not, you get one because anything could happen at any time.
Mm-hmm.
You don't want to be up the creek without a paddle.
Absolutely
I'm
not.
not saying everybody needs an IV, but, like, if you have a sick patient and you can't do it.
There's nothing that I'm necessarily going to give you in the moment, but one, that doesn't mean things aren't going to change.
Yeah.
And it's like your course of care.
Mm-hmm.
You're going to get a line in the ER.
Yes.
And the argument is, I think the argument is, like, cleanliness and starting lines in the field.
Guys,
and
what do you
dirty
think we're doing?
Also, like, do you clean your site well? Like, if it comes back brown, get a new alcohol swab and scrubby again.
That's a 2-pad job.
Right? That's a 2-pound job. But also, have you been in an ER? It is just
also gross.
as disgusting.
But side note, I would like to plug this. If you are having issues with infection rates at your service, give your crews the items to fix that.
Oh, yeah.
Can we please, for the love of God, take alcohol preps out of EMS? Chloropreps for everybty.
You just get the start kits with Chloropreps.
Get Chloropreps. Get the swabby caps for the IVs.
Yeah.
Swabby caps.
It's easy peasy.
They're fixable issues.
Mm-hmm.
Anyway, that's my soapbox. Go ahead.
It's one of my favorite soapboxes you go
I know,
on.
I knew you were going to
Swabby
talk about
cap
the
for
swab
life.
caps.
Well,
It
swab
is
cap and
important.
chloropreps. Like, for the love of God, I cannot understand, besides money, which I understand that's what it is, but I cannot understand why we use tiny, tiny little 1x1 alcohol
don't
preps
know
that I
either.
can't even feel through my gloves that sometimes ride up on my finger and I don't even know it, and I'm just rubbing my glove on a
Honestly,
patient.
I just want baby wipes. I need to baby wipe you, and then I will.
Right.
Or
That would be
that, yeah.
nice.
Yeah, that would be
But,
nice.
like, just fucking chloroprep.
But, like, have
Give
you
me
ever
chloropreps.
gone into an ER and unless a patient is like literally covered
In doo-doo?
in poopies, unless they're literally covered, like they don't get a bath. There's no showering. They're
Yeah.
not like, you know what, sir, go take a shower and then come back. That doesn't happen. They start an IV on the same arm that we started an IV on with the same amount of dirt on it.
Yes.
With the same equipment that we start IV.
And I
Yes.
can
Yeah.
guarantee you that we're most of the time starting an IV the same way as the
Mhm.
tech in the ER is and the nurse in the ER is.
Oh, yeah,
Like,
'cause
100%.
We also sometimes are those techs in
Yeah.
the ER.
Yeah. They're
Yeah. so that non-issue in my opinion.
100%.
Non-issue.
Like when I worked in the ER, I started lines the same way I start them on the truck.
Yeah.
Which is the correct way.
Right.
yeah,
which is
we
just-
don't do it wrong.
No.
Yeah, no, it's the same. It's the same.
I was gonna say that Jamie brought up a good point. She was talking about like in the anticipated, like the patient is gonna get an IV. Like sometimes we do things and they are appropriate because of anticipated clinical course. Sometimes we RSI people because of anticipated clinical course.
Mhm.
Sometimes we give meds because anticipated clinical course.
Right.
Like there's tons of things we do because we are anticipating this patient to require them, or like it's going to go south. Sometimes we just have to do things.
We don't use that phrase a lot in EMS, anticipated clinical course, and a lot of other areas of medicine do use that phrase. But we learn about it. We just don't know that's what we're learning about.
Yeah.
Like when you learn about an anaphylactic patient and you see like angioedema and you have a wheeze, or you are that's heading towards stridor, and your first round of meds have not worked, that is a patient that you RSI because of anticipated clinical course. And maybe not if they're still talking to you in full sentences and being like, hey, bro.
Yeah,
But if your first round of meds has not worked and they continue to worsen, odds are they will continue to worsen. And so anticipated clinical course, that would be a
Take the
patient
airway.
you RSI. You take that airway before you can't.
exactly.
And we learn that. And we all know that. We just don't use that phrase with it. And I think that if we use that phrase more often with other conditions, we would do more appropriate interventions sooner.
Yeah. I also think that, like, if you have, we'll just use the term, like, ALS this call, okay? There's a paramedic riding with it because, or depending on your state, whatever, there is an ALS call. You've deemed this patient to be, like, you know when you're filling out your narrative or your charting or whatever, and it says, like, for us, we have ESO, and we have to put, like, essentially, like, a pseudo triage. We're putting in potentially unstable. That's yellow for us.
Yep.
They could potentially become unstable just based on their complaint alone.
Yeah.
Like, we don't have all the things to rule out
Mhm.
something that could be killing them right now.
For sure.
So if you're marking that, I'm sorry. They need an IV.
Get a line.
Potentially unstable.
Mm-hmm. And you're right. Almost every patient you ALS, that's the risk. Right? And how many of us have looked back at patient outcomes and been like, oh,
Whoa, that was
oh
a
no.
scary surprise.
They died how many hours after I dropped them
Yes,
off?
it'll just say expired. And
Yeah.
I'm like, oh my God.
Or something just crazy.
My medic
Like,
license? What the
What
hell?
the heliante?
Literally.
But we will just look at that and I'm like, oh, I did not see that coming at all. But then I think about it and I'm like, it was a 45-year-old female. Recently has been more lethargic than normal. Was complaining of like restless legs the other day. Now she's like short of breath, but just thinks she's anxious. We ALS'd it because she'd been having like intermittent pain. Cool. Okay, well that, when you look back at it, you're like, oh, that sounds like PE.
Yeah.
Right? But those are patients that like if you get a line because you ALS it, even though you're like, I don't think I'm really going to give her anything right now, she could code in 10 minutes.
Mm-hmm.
Right? And I think it's those that
Potentially.
is always my argument for like, just do it.
I don't know a single person in this field who hasn't gotten burned
Mm-hmm.
thinking it's probably not that bad.
Yeah, it's
Nothing's probably. I think
Mhm.
I say this a lot. If the answer is maybe or probably, the answer is no. Okay? And what I mean by that is, if you think, well, maybe, well, probably not, that's it. You need to either be so sure that nothing is going to happen, or you need to
like
plan for something to happen.
You know, like socially, where someone's like, hey, do you want to go do this thing next week? And you'll be like, maybe, let me look.
The answer is no.
Yeah, the answer is no.
They're not going.
I mean, no. I think in medicine, if you are, the answer is always the opposite of basically what you're trying to avoid. That's the answer. Because in medicine, people will be like, well, I mean, could it be? And you'll be like, I mean, it could be. Yes, it is.
Yep.
That you just need to go on that. Like, if you're like,
well, maybe.
No, go with the worst possible thing that it can be. Yes. Especially when you're in our position.
That is our job.
You don't have specific certain diagnostics. You don't have labs. Like, we just don't have so many of these things. So you're going with your gut most of the time. And like an end title. Just your gut and an end title.
The vibes, your gut, and an end title.
That needs to be a sticker.
It does.
Just the vibes and an end title. But that's that's the wave you're riding. And so
the waveform you're riding.
If you go, if you start with like your worst possible diagnosis and work your way down, worst possible case scenario in your ALS run probably starts with an IV.
It's kind of like putting the pads. Lead. Yeah.
Just do the 12
Just do
lead.
the freaking 12 lead.
You can put 4 stickers on. I promise you can put on.
That's my thing. If you're putting 4 on, unless it's just like.
You can put on another 8.
Whatever. A young person who needed some fentanyl or something.
You know, but I think like the old school mentality was that they used the 4 lead to rule out the need for a 12 lead.
Which doesn't make sense.
It does not make sense.
You can't confirm anything without the 12 lead.
Without the 12 lead. But I don't think that's the way they were taught. Yeah. Because I think they only had the 4 lead for so long that when the 12 lead came around, it was like the next. It was like BLS to ALS.
Yeah.
And so I think that if they don't see anything curious on the 4 lead,
then it's fine.
Then they're like, we don't need a 12 lead.
Yeah.
And we did not learn them that way. We learned them.
Doc Dave said you cannot confirm anything without a 12 lead, and he is right.
100%. Like the 4 lead for me is basically just like, is my rate the same as my pulse ox?
Or is there something where I'm like, put that on immediately?
Absolutely.
That's literally
like that's it. Most of the time when we do a 4 lead, it's just because we're giving meds that technically require cardiac monitoring.
Yeah.
Like Zofran or whatever it is. But almost never are we just like, no 12 lead for you.
Yeah, like it's not that much harder.
Yeah.
No.
May as well get it, transmit it. Why not?
You're just collecting more information.
Yes.
They're already ALS, so why not?
And that is what I'm saying. Like, we just need to collect as much data as possible so that we are making sure, A, we're taking these patients to the appropriate facility. Because there could be something. There are so many times. Remember that I had an anxious patient, and he told me, he's like, I threw up, and now I have really bad health anxiety. I'm freaking the out. And I was like, okay, you are freaking out. He we couldn't coach him. We couldn't get him to stop. He had the tallest T-waves I had ever seen in my ding-dang life.
Oh, my goodness.
That was the one who his potassium was over 7.
Yeah.
It's her.
Okay, like it
You're
does.
anxious
You
'cause
may
her heart
find
is freaking
something
out.
that the hospital would have never found because he said, I'm anxious. I know this about myself. I have a history of anxiety. When I throw up, I panic because I think I'm dying, whatever. Okay.
Yep, and they would not have.
They wouldn't have done that because he was a young person, very young, like in his teen years still, who just said, I have anxiety, I'm experiencing anxiety, this happens to me.
Yeah.
Like, it matters. Yeah. And, like, that's the point, is, like, gather all that information while you can. Can't really do 12 lead effectively when transporting. So, it's not about why you were on scene for 28 minutes or 30 minutes or 20 minutes. It's about what you were doing in those minutes.
For sure.
Like, what were you doing? If you were doing stuff that matters.
Yeah. And whatever you're doing may be more valuable than the offset of that time.
Yes.
And even coming down to, like, collecting information, like, from family, like, things on scene. Like, there's information that is invaluable that the ER, it may change their clinical course based on information that we know. Like, the kid that you just talked about that had hyperkalemia. It also depends on if we take our patients seriously or not, because the amount of times that I have been like, oh, this is just bullshit. And it was, but the ER listens to you when you say that.
Confirmation bias.
Yeah. And so if you come in, you gain rapport with your charge nurses and all the things, and hopefully that's in a good way.
Yeah.
But if you come in and you're like, oh, like, this is just anxiety, he's chilling. Like, he's just freaking out. We just can't get him to calm down. You go to the waiting room, and that's it. But I think it depends on if you take the time to dig deeper. It can, like, really affect. Because the ER, when we bring them in, does not start from a 0.
Yeah.
They start from whatever we bring them and then go off from there. And so I think that that's a good point to make, that what you say it is really they step off from that point
for the most part. And what the patient, I was like, you don't really look great. Like, I know you're young and you've threw up and whatever and you're panicking, but I was like, something's weird.
Yeah.
But like, truly, like in the ER, like, he's saying what he has, what he has a history of, which is a benign thing. He's at an age where benign problems happen.
Yeah.
Like, so that's why I'm just like, just do the ding ding wobbly.
Just do it.
Something that I've started telling medic students is, because sometimes we'll be on calls and it'll be something like getting a 12 lead versus a 4 lead or whatever, or like maybe going an extra step in documentation, or like transmitting the 12 lead, whatever it may be. Because some of them will be like, well, I really don't think it's that. And I'm like, no, I don't think it's that either.
I didn't think it was going to be that.
Yeah, but you're not, when this patient leaves this ambulance and when your run ticket gets sunk into the depths of the ocean, they don't get to see what happened in these 4 walls. They don't get to see this patient. So you're not defending what's going on right now. You're defending yourself on paper of what it could have been. So like, gather all of the things that you could possibly gather, because you're just defending yourself and this patient. That's all you're doing, and that's fine.
I always say, like, you'll hear us, or really all of us do, but you'll hear us say, like, follow the vibes, right? Like, follow your gut.
That matters.
It does matter. Don't always follow your gut if it means that you're going to collect more information.
Yeah.
You cannot justify on paper following your gut to do nothing.
That doesn't even make sense in my brain.
Right? So if you're like, I just really think this patient's full of it.
Yeah.
Like, this is just, none of it's tracking. The story's not adding up. Like, they're changing details. You're just like, okay, seems ridiculous. Like, you did not pass out 74 times today. This is absurd. Yeah. Right? And we've all had those patients where we're like, you're just bad at whatever you're making up. You Wikipedia'd too hard. This is terrible. But can I document that well? Like, is that going to translate in documentation that I was basically like, this is all BS? That's going to be really hard to write down. So my gut is telling me none of this is real. Yeah. But can I document that? No. So I do the things that I have to do based on protocol. And I write down their complaints. And then I write down, like, you use a phrase that I love so much.
Stated complaint not observed.
I think it is. I think it's stated complaint not observed.
That's like in our
Sophie
thing.
Says that.
Yeah. Is that yours? Yeah. Okay. And that's like one of my favorites, because it is a great way to say, like, I am not seeing any signs or symptoms of what they're telling me. Yeah. But this is still what they're telling me. Yeah. But that's always my, like, rule. I will follow my gut, like, off a cliff into what I think is wrong with this patient, but not the other way around.
I have to have quantitative data to back me up on paper.
Yeah, absolutely.
Because I'm not always going to be pleading my own case. Mm-hmm. Paper pleads my case.
Yep.
90% of the time.
Yep.
So, yeah, you have to have things written down that will speak for you.
Mm-hmm.
Our job is science, and science is just data collection.
100%.
Oh, yeah.
Like, that's what we're here for.
Yeah. And, like, we've all occasionally been in those places where you get to the ER and you find the doc and you're like, I know that this does not sound like anything significant, but please just trust me. Like, look into this. I think something's wrong. Yeah. Like, I think something's up. Like, you had one of those the other day that you went and found the doc at the ER and you were like, please just, take this kid seriously. Like, something's wrong. And we've all had those without, like, great data. But again, if it is in the forward momentum direction, like if it's pushing care forward, follow it. Yeah. If it's pulling care backwards, do not.
Yeah, you have to be able to defend. Mm-hmm. And the point is, like, our job is literally to essentially make it, like, we need to prove that you're not dying right now. Mm-hmm. And if we can prove that you're not dying right now, then we don't have to do anything.
Absolutely.
But, like, if we can't prove that you're not dying and then we still did nothing and then you died, then we didn't do our job.
Yeah. Right. And I think that a lot of providers think the opposite. They're like, you have to prove to me
that you're dying.
That you are dying right now. Mm-hmm. And it really should be that we have to prove to them that they're not.
People be looking real fine and then just die.
Mm-hmm. Mm-hmm.
Also, we have a blog post up on our website, and it's about I think it's titled, like, Eventually They'll Be Sick, and it's about regulars.
Mm-hmm.
And I think that's something to talk about,
Yep.
too. I know we're kind of derailing, but, like, it goes, the same point stands here, is, like, you could be dramatic as hell. Eventually the drama queen's going to be dying.
Mhm.
Eventually the regular's going to be dying.
Yep.
And some people just are dramatic at baseline, and they're still dying.
Yeah.
Like,
It just is.
yeah.
It's
Sometimes they just are, and you're
Listen.
like, what? How did you get to this age being this dramatic? Like, sometimes that's what I think about.
How did you
Yeah.
make it this far?
Yeah.
Or like we had a lady that was like, I float up.
Yes. I'm like, have you never thrown up
Have
before?
you
You're
never thrown-
90.
You're 90. Have you never thrown up before?
Yeah.
Oh my
So-
God. Or like, is it just you're at an age now where you're like, this something's bad wrong?
I'm dying, yeah.
Like I'm bad.
Yeah,
bad.
This
now
is it.
every throw up, you're like, this is
This
the
is
end.
it. This is the
Yeah,
end.
I'm down bad,
I
man.
don't know.
I'm down bad, man.
Well, I think that it's important just to remember that there is no official standard. There's no national standard. There's no
Mhm.
national recommendation. There's no, like, standard of care that says you have to be on scene for X amount of time.
Mhm.
There's obviously things that the only thing that's gonna fix this is get to the hospital, like STEMI, stroke,
Absolutely.
certain things. But, like, if you are spending your time wisely and doing appropriate interventions and care, I just combined interventions and care
I like
instead of
inner care.
Inner care.
if you're doing the right things, that is justification in itself, in my
Mhm.
opinion.
Yes, and I like your point that it's just swapping time.
Yes.
If you're managing it well, it's swapping time. And I like your point that we are the only place in the medical system that they're going to be 2-to-1,
Mm-hmm.
except for like the cath lab. But like,
Yeah, when we get to the hospital, that nurse has lots of patients, and she
Mhm.
may even need to help some other nurses.
mhm.
Like,
not to mention how many patients that physician has.
right. Like, it's just
Yeah.
unrealistic, or maybe a little bit ridiculous, in my opinion, to
Yeah.
say, we'll just make those people who have more work on their hands at one time do
Yeah.
the job that we could do right
We're
here.
right here, right now.
Mm-hmm.
Where we have 2 people to start one line.
Yeah.
That's pretty dang good.
Right. I think that if we're trying to merge EMS into the rest of medicine,
Right.
and
We are trying to prove that we are medicine and not.
right,
Like, right now we fall under transport.
right, we're a part of
NHTSA.
like DOT,
Yeah.
which what, but like, if we are going to merge ourselves like seriously into the healthcare system, then we need to stop treating it like we are just
Right.
transport. Because like if our own EMS agencies are like grab them and go, well, essentially you're ignoring any piece of data or anything that shows that EMS is even necessary.
Yes.
Because if we're just grabbing people and going, we can go back to the Hearst days.
Also, when has quicker ever been less chaotic?
Oh my gosh, I know.
When has it ever been less chaotic?
If you're providing appropriate intervention,
Just
steady.
like we
Slow
talked
and
about
steady,
last
guys.
week, RSI. The
Yep.
most calm RSIs are snail pace.
Mm-hmm.
It's just how it is.
Yep.
Because it's chill. Obviously, like we said, some things need to get to the hospital yesterday. But, like,
Yep. Yeah, some things we get there and they should have already been there. And we're
Yes.
like, oh, geez.
faster is not less chaotic.
Mhm.
And I think as far as like getting access, you can have a set like pull out time in your brain.
For sure.
Like I'm going to try, if I don't get it by at least 3 tries, like this person is sick enough, we have to go. You
Yes,
know?
yeah.
Like I'm not saying send an hour on scene because you need to get a 20 in their left thumb.
Oh,
Like
yeah, no.
that's not what we're going for here. But just don't write it off at the beginning. You know?
Yes, and that's what we mean by use your time wisely.
Yes.
If you don't want to sit on scene for an exuberant, that's not a word.
I sounded
Exuberant.
like one.
Yeah,
I think I
exuberant.
added extra
You
letters.
added,
in there.
like, mint in
Ring
there.
One
around
extra
it.
syllable, but I liked it.
You don't need to spend like an exuberant amount of time on scene.
Right.
And like clearly manage it appropriately. Don't be inappropriate.
Excessive is problematic. also.
Absolutely. There are plenty of times that we'll be on scene and we'll both try for a line and not be able to establish one. And I'll
Yeah.
be like, all right, let's go. I'm going to keep trying en route.
Yeah.
Like that's acceptable. But don't just be the person that, especially double medic crews, where like one medic gets in, the other one shuts the door and they just start driving.
I don't like that.
it's
And that
like, let's
happens a
just-
lot.
Oh yeah. And they're like, well,
They're like, I'm good. I'm like,
we'll just see what we can get done.
well, and if
on the
you
way.
are having
Like,
scene times
what do you mean?
consistently that are like 10 minutes or less, are you even assessing your patient?
Yeah.
Because there's plenty of assessments that are way more difficult to do
Mm-hmm.
alone and when you're driving.
Mm-hmm.
Oh yeah.
If you did everything you needed to do in 10 minutes, plus, like, this means you arrived on scene, you got out of the ambulance, you brought everything you needed to the patient, you assessed the patient in their environment enough to get a good idea of what's going on, you put them on the stretcher, you brought them to the ambulance, then you did your interventions that are appropriate for the ambulance only, and then you transported in under 10 minutes, and you assessed them effectively? No, you didn't.
Mm-mm.
A sick
Mhm.
patient. for example.
Yes, not like someone that met you in their front yard.
Right. I know, it is crazy. That's what I'm saying. Like, if
I'm
you're
like-
doing Speedy Gonzalez transports, then you're probably not assessing your patient. I always document, I say, when in my little transport section, I put initial assessment and interventions performed prior to transport. Once these were completed, transport began.
Yeah.
Like, there are things that are just more appropriate to do before you
Sitting
start
still.
driving. One
For
of those
sure.
might be, like, placing leads on a patient that is a woman and you're a man, or, like, things like that, where
Yeah.
maybe you just need a chaperone. Like, there are
Yeah.
situations.
For sure.
Like,
Yeah, especially like if you have like if you're a dude and you have like a young female patient,
Yeah.
or like
Please get a
any
chaperone.
different dynamic like that.
Mhm.
Please keep your partner back there with you,
Yeah.
or one of their people, or a significant other, or a parent, or like whatever it is.
yes.
Keep eyeballs on you, and that's just CYA.
Yes.
Like to make sure that you
But
are
that takes
covered.
time.
But
Take
that
the
takes
time.
and you can't be driving while you do it.
Right. Take
Mhm.
the time.
Yeah.
It's okay.
Yeah.
That's why I don't like these blanket rules about things.
Yeah, that's like you will under no circumstances will have a scene time longer than 10 minutes.
Yeah, that's asinine.
And it can be reckless.
It is. I think it is. If you have a sick patient and your scene
Mhm.
time, which they're sick, obviously, chances are they shouldn't be walking or they can't walk.
Yes. And just because they're damn near dead when you get them to the hospital and not all the way dead doesn't mean you won.
Oh, yeah. Do you know how terrible
like, it
I
doesn't
feel
mean
when I have
that
to
you
put
did a good job.
did not
Worse.
like, worse on arrival?
Yeah.
I literally want to cry every time.
Yeah. Just because they're damn near and not actually dead does not mean you did a good job.
No.
It just means that you drove fast.
If you did nothing and just got them to the hospital, then why are you doing this?
Mm-hmm.
That's what I want to know. Like, why are you here?
Right?
Do you even like this job?
Right. The only time that should be the reason is if it is literally a complaint that do nothing is the only option.
Yeah.
Like you have a kid with epiglottitis.
Yes. That's the only scenario. That really, officially, is probably the only scenario.
Do nothing. Let
Yeah.
mom hold kid. I don't care what you have to do. Do nothing.
No
Don't look at
sirens.
them.
Yeah. Don't. If they hate you, don't
Put
talk to
Bluey
them.
on.
Yeah.
That is your intervention. It's still an intervention.
That is
Yes.
Comfort
literally.
care.
right. Like that is a scenario where do nothing is appropriate. But even strokes,
You need
which
IVs.
like for the most part,
12
we
lead.
don't do for strokes. We get them somewhere fast,
Mhm.
but get line.
Yeah.
Get a 12 lead. Make sure we're not double clotted.
Yeah,
Double clotted
Austin
up.
has that story. It was a younger person, like a
Mhm.
44-year-old, 45-year-old female or something,
Mhm.
having a stroke and a STEMI.
Mhm.
Why her clot burden was so high, I have
Yeah,
no idea. But
She was clotted
it's
up.
still part of your job to check those things.
Mhm.
Yeah.
With that, do your assessment, do your initial interventions that are appropriate
Mhm.
prior to transport. If you have a sick patient and you have a very minimal scene time, you actually better explain that one.
Yeah. Be responsible with your time in both directions.
Yes. Yeah. And fast is not always better, even
Mhm.
though we tend to have a need for speed in this field.
For sure. I would argue that the closer you are to a hospital, the longer your scene time should be.
Yeah, I think that's
Agreed.
appropriate.
Right.
Agreed.
If you have a 50-minute transport, 50-minute
Yeah,
transport, and you want to hit the road out the gate,
fair.
Cool.
Fair.
right? You want to get a 12 lead go.
Yeah.
I'm on board because you have a lot of time to get a lot of interventions done and
A
things
lot of
that need to
assessment.
happen, and you have a long transport, so you have to be aware of
Yes.
that. If you have a 5-minute transport to the ER, that 5 minutes is not 5 minutes.
Yeah.
Because it's 5 minutes to your truck, 5 minutes to the ER, 5 minutes to get them registered, 10 minutes to get them a room, 10 minutes for the doctor to come in, 10 minutes for the orders to go in,
Yeah.
another 10 minutes for the nurse to even see the orders,
Hours.
20 minutes for the orders to happen. Like, it can literally be hours
Mhm.
before they receive any care. So even if you're 5 minutes from the hospital, that's not 5 minutes.
And think about when you're calling report. If you're 50 minutes away and you call report 10 or 15 minutes out, that is 40 minutes, 35 minutes to do interventions and assessment. So you get a good idea of what the heck is actually happening
Absolutely.
with this patient. If you are 5 minutes away from the hospital and you have to call as soon as you get in the truck, what the heck are you going to tell him?
What in the hell? Like, what are you?
What are you going to tell him? Like, it does matter.
Be like,
Again,
found them. They look not good.
they said ouchie. So I agree with that. If you are close, scene times probably need to be a little longer so you
Mhm.
actually know what the heck is going on.
Mm-hmm.
If you're really far away, yeah.
Yeah,
I get it.
Use the philosophy of Aubrey. It's not delaying care; it's swapping time.
Bingo.
This has been Life in Sirens. produced by three nerds trying to bring you content that you might actually care about.